Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go to reallifepharmacology.com if you haven't got that free 31-page PDF. That's a no-brainer. Top 200 study guide. Great refresher on some of the most important things you're going to see in practice, as well as things that show up on board exams and pharmacology exams throughout your career. So go get that. Simply an email will get you access to that. Also, a reminder while you're at reallifepharmacology.com, go ahead and hit the podcast tab and search if you're looking for a specific drug, maybe even a class of drugs, that type of thing. We've got well over 300 podcasts on various medications and topics. So go check those out as well and get some more education. All right, let's get into the drugs number 191 through 195. Just a couple of episodes away here from finishing up the top 200. First medication is Plavix. That's a brand name. The generic name is Clopidogrel. This is definitely a commonly used antiplatelet medication, also classified as a P2Y12 inhibitor. Primary indications for this, acute coronary syndrome, can be utilized for thrombosis prophylaxis, basically in general. Recent MI or stroke, this is a medication that you might see used in that setting. Peripheral artery disease, it can be used for that too. So from a mechanism of action standpoint, this is kind of a unique medication. It is a prodrug, and this is something that definitely comes up on pharmacology and board exams all the time. So Clopidogrel is a prodrug. It's activated most notably by CYP2C19. So that enzyme actually activates the drug and, obviously turns it into its active form. So that active form or active metabolite, this ultimately binds to the P2Y12 receptor, which prevents the binding of adenosine diphosphate, and ultimately all of that results in the inhibition of platelet activation and aggregation. Okay, so that's how this medication works. Again, that's CYP2C19, particularly, maybe at higher levels, pharmacy school, med school, that type of thing. That's definitely something that comes up frequently with this medication. Dosing, what I see in an ambulatory care setting most often is 75 milligrams daily. It can be a loading dose as well in ACS, so an acute coronary syndrome type thing, where we give much, much higher doses, 300, 600 milligrams, for example, in certain situations. Adverse drug reactions. The biggest thing I'm concerned about with this medication is bleeding and bruising. In clinical practice, I really haven't seen much else other than that. So, that's kind of the primary thing that we're going to be monitoring patients for. And we're going to do that through, obviously, patient assessment. If the patient says, hey, I've got a lot of bruises, but also we can, check hemoglobin. We can follow platelets as well. With that CYP2C19 piece of it, there is a boxed warning. In patients who are poor metabolizers at that enzyme, they may have reduced antiplatelet effects from this medication. So it may not be as effective as we would like it to be if somebody's a CYP2C19 poor metabolizer. All right, finishing up this medication, let's touch on drug-drug interactions. So anything with antiplatelet, anticoagulant type properties, that's going to potentially enhance the bleed risk. So that is definitely something that I look out for there. Most notably anticoagulants, apixaban, warfarin, NSAIDs also have antiplatelet activity. They may increase the risk for things like GI bleed, for example. So again, paying attention to other medications that may increase the risk for bleeding. And then, of course, we can have interactions through CYP2C19. So if we've got an inhibitor at this enzyme, fluvoxamine being a classic example, omeprazole is another example of kind of a moderate CYP2C19 inhibitor. This can potentially reduce the effectiveness of the medication. And I've blogged at meded101.com before on the omeprazole and clopidogrel interaction. So if you want to go dig into that a little further, I'll throw that out there as well to go take a peek at that. On the flip side, and probably last, I'll touch on CYP2C19 inducers. Again, not incredibly common. There aren't many medications that do this, but rifampin is kind of a classic example, antibiotic that's a strong enzyme inducer. That can actually cause more of the clopidogrel to become activated, and you could potentially get a higher therapeutic action, therapeutic dose, however you want to approach that, and it may increase the risk for bleeding there. All right, moving on. Next medication, we've got Vibromycin. That's the brand name. Generic name is Doxycycline, which that's the generic name is used much more common in practice. This is a tetracycline derivative or a tetracycline antibiotic, and it can be used for a wide variety of things, from STDs to pneumonia to skin and soft tissue infections, acne, rare bacterial infections like tick-borne diseases. So definitely a lot of potential coverage with this medication, and I think that's probably one of the reasons why you see it used frequently there. It does have MRSA coverage, so MRSA is one of those kind of drug-resistant bugs. So in an outpatient setting, this is available as an oral medication. That may be a kind of a unique use for this medication there. Mechanistically, doxycycline binds to the 30S subunit of the bacterial ribosome, and the big bullet point here is it inhibits protein synthesis of the bacteria, and obviously inhibits that bacterial growth and replication. With the dosage forms, we've got oral, we've got intravenous, so that's a nice thing with this medication. It's ideal to take this with a significant amount of fluid. Most of the time I'm just going to recommend a glass of water, for example. The reason being there is a potential for it to kind of get sticky and irritate the esophagus, and potentially, even in rare cases, cause an esophageal ulcer. So with the oral tablets, oral dosage forms, we want to make sure that we're keeping that medication moving. We can give this with food as well to kind of reduce any GI upset and GI irritation. All right, adverse drug reactions, skin photosensitivity, so an increased risk for sunburn. This is a good patient education point there. With any antibiotic, GI upset, diarrhea, definitely a common potential concern there. That esophageal ulceration and irritation can happen as well. Rarely, there's some skin reactions that have been associated with it, may increase the risk for C. diff, and hepatotoxicity has been reported as well. Drug-drug interactions. Let's get into that a little bit. So binding interaction is probably the biggest thing that I see in my practice. I've got a lot of polypharmacy patients, a lot of patients on iron, antacids. These can bind up the medication and ultimately reduce its effectiveness and the amount of medication absorbed. So really got to pay attention to that timing or the administration timing. 2 hours before, 6 hours after, that type of thing with this medication in association with iron, antacids, and other medications that may bind it up. So again, pay attention to that for sure. If we're giving this medication multiple times per day, doxycycline is usually dosed twice per day. If that separation is not possible, let's say somebody can't take, their iron supplement in the middle part of the day, well, most often we're going to use antibiotics for very short term, so we can probably get away with holding it, holding the iron or calcium or whatever supplement we're talking about there. If it's just 5-day course, 7-day course, we're probably not going to significantly damage somebody's iron stores, for example, or calcium supplements in that short amount of time. So I have had a few circumstances where I've recommended that or done that. Again, we can usually get by with just changing the timing, but something to think about there. The other thing I did want to mention is oral contraceptives. There is potentially some evidence that it may interfere with the effectiveness of oral contraceptives. How strong that evidence is, again, I think it's a good patient education point, saying, hey, maybe you want to use a little bit more caution here. But again, there's kind of been evidence back and forth on certain antibiotics and others not so much. So again, always a good thing to think about, that use of oral contraceptives when we're giving somebody a new antibiotic, because there are some that will interact more than others there. If you're a pharmacist or pharmacy student looking for study materials for your board certification exam coming up, go check out meded101.com/store. We've helped thousands of candidates prepare and pass their board exam. We've got BCPS, NAPLEX content, ambulatory care, geriatrics, BCM, DMS. Again, go check that out, support the sponsor, get a great product, help pass your exam, and obviously help support the Real Life Pharmacology podcast as well. Thank you so much, and I hope you enjoy the rest of this podcast episode. All right, next medication is Hyzaar. We've got a combination medication here. Hyzaar is the brand name. We've got Losartan and hydrochlorothiazide. So this is an ARB, angiotensin II receptor blocker. That's Losartan, and a thiazide diuretic. That's hydrochlorothiazide. And this type of combination pill is advantageous in patients particularly that are on a lot of medications already. Rather than separating them out and patients now have to take 2 pills instead of 1, we can really kind of reduce that pill burden. Now, it doesn't take away any adverse effects or any risk that way, because you're still getting the medications, but to the patient it may feel like a little bit reduced pill burden, which is typically a good thing. Primary indications, hypertension. Again, that Losartan is that angiotensin II receptor blocker. So again, angiotensin II is a potent vasoconstrictor, which can obviously raise blood pressure. And then hydrochlorothiazide, that inhibits the sodium chloride cotransporter within the distal convoluted tubule. This leads to decreased sodium chloride reabsorption from the urine. It increases the excretion of sodium in water, which can ultimately lead to kind of a lowering of blood pressure there. Administration, not too much finicky there. Can do with or without food. Be a little cautious with the hydrochlorothiazide later in the day. Can cause some frequent urination, so might cause your patients to get up at night if they take it too late in the day. Adverse drug reactions, so dizziness, if we drop blood pressure too far, this may be more common that you run into that. Hypokalemia, so that hydrochlorothiazide piece will drop potassium levels. And on the flip side, the Losartan will raise potassium levels. So in theory, this is kind of a good combination to make sure those potassium levels are evening out. We're going to want to monitor renal function. So there is the potential, with hydrochlorothiazide and with ARBs, for example, that these medications can cause insults to the kidney. So we're going to monitor that kidney function, eGFR over time there. Other electrolyte abnormalities are possible. I've seen, low sodium with hydrochlorothiazide, for example. Also, rarely, maybe some elevations in calcium with hydrochlorothiazide. So, a couple things to keep in mind there. And then hyperuricemia. So, patients with gout, we may cause those uric acid levels to go up with the use of hydrochlorothiazide. So, again, we're going to kind of pay attention to that and make sure we're okay there. One note of kind of a warning, caution with Losartan is it is contraindicated in pregnancy. So making sure we're aware of that and recognizing the patient population that we're using this medication in. All right, drug interactions. So I think about nephrotoxicity risk. So if we add on, NSAIDs, if we add on, a loop diuretic in addition to what they're already on, that could increase the risk for nephrotoxicity. Important to think about avoiding ACE inhibitors. So, somebody might see the brand name Hyzaar listed there, or they may see just the hydrochlorothiazide listed and not recognize that they're on Losartan. We shouldn't use an ACE inhibitor like lisinopril with Losartan. And then the last thing I do think about, I alluded to the increased risk for gout flares, elevations in uric acid potentially with hydrochlorothiazide. So keep that in mind. If you see a patient on medications that are being used to treat gout, that hydrochlorothiazide could be worsening that condition. All right, next medication is, brand name is Kytril, generic is granisetron. This is a 5-HT3 inhibitor, also kind of more broadly classified as an antiemetic. Its indication is nausea and vomiting. So it's antiemetic. Again, we're going to be using it to reduce those risks. Primarily, I see it, in association with chemotherapy-induced nausea and vomiting. Its cousin is ondansetron, which is probably a medication you see used much, much more often. But mechanistically, granisetron is an antagonist at 5-HT3 receptors, which are present peripherally on vagal nerve terminals and centrally at the chemoreceptor trigger zone in the brain. This ultimately blocks serotonin from binding these receptors and reduces that incidence of nausea and vomiting, which again is often triggered by chemotherapy, and or radiation. All right, adverse drug reactions. Mostly, I've seen kind of central nervous system things with this medication and this class medication. Potentially for some sedation, maybe a headache. Maybe some dizziness or cloudiness, patients not feeling great that way. I would say those are probably the primary things that you're going to see there. Rarely, may cause some, diarrhea, some, GI upset in general, but again, probably going to help more than hurt when it comes to, relieving some of those symptoms of nausea and vomiting on the GI tract there. Rare serious adverse effects. Two things I think about, QTc prolongation as well as serotonin syndrome. And as you can imagine, those are probably going to come up in the drug interaction section as well. So, alluding to that, the drug interaction risk, macrolide antibiotics, azole antifungals, fluoroquinolones, antipsychotics. These are all medications that can cause QT prolongation, can have that additive effect on top of granisetron here. And then the serotonergic agents, SSRIs, tramadol, TCAs, SNRIs. Again, these can all kind of have additive effects and increase that risk for serotonin syndrome. All right, last medication, number 195, is Restoril. That's the brand name. Temazepam is the generic name. As you could maybe guess from that ending, this is a benzodiazepine. And its primary use, because it's got a very short half-life, is insomnia. That's where you're going to see temazepam used most often. That's what I've seen in practice there as well. So mechanistically, it binds to GABA A receptors, and this kind of stimulates or potentiates the inhibitory effects of GABA on the central nervous system. So kind of those things that you're going to feel with this medication, the drowsiness, the sedation, somnolence, dizziness, increased risk for falls, that's what you're going to see with this medication and, in general, all benzodiazepines. So pay attention to that for sure. A couple other things of note: it is a controlled substance. It's Scheduled 4, so obviously we've got risk for abuse and dependence. This medication and medication class in general does fall on the Beers list. Not the greatest medications to use in the elderly. They increase the risk of falls, fractures, central nervous system confusion type symptoms. So again, we do our best to try to avoid benzodiazepines if possible in our geriatric patients. On the flip side, if you're looking for a medication and you're going to utilize a benzodiazepine in an elderly patient, it is typically going to be one of the preferred ones for insomnia because of that shorter half-life. We don't get that lingering, hopefully, of those adverse effects kind of into the next day. So again, kind of a little caveat there where it's not a great medication to use in geriatric patients, but within this class, if you're looking for a medication for its insomnia management purposes, this is probably going to be one of the more preferred benzodiazepines in that situation if you've got to use one there. With use in insomnia, there have been complex sleep behaviors reported, sleepwalking, sleep driving, for example. So that's something that we want to caution patients and or caregivers about, that there have been some reports of abnormal behaviors, sleep-type behaviors when taking this medication. Some warnings: really careful with opioids and alcohol. They can have excessive kind of sedative or additive sedative type properties, so definitely be careful with that. With opioids more specifically, we can get that risk for respiratory depression. So again, super careful with that, paying attention to that risk for sure. That kind of ties into the drug interactions with this medication. So first and foremost, I think about the CNS depressant effect. Are we on other meds that can have additive effects to that? Benzodiazepines, first generation antihistamines, other sleeper type medications, for example, opioids, alcohol. These are all medications with sedative type properties. Can definitely enhance or make that worse when we add temazepam on top of that. Antipsychotics, kind of another example there, where we can have that additive sedative properties, gabapentin, pregabalin as well. So again, pay attention to that CNS depressant type activity. That's probably the biggest thing I think of when I think about drug interactions with benzodiazepines and temazepam in general here. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls. If you did, do me a huge favor, leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. Share us with friends, colleagues, students, other healthcare professionals who may benefit from some pharmacology education. This podcast has been downloaded, I believe we're upwards of close to 5 million times, and that's a big number that I'm really proud of, and it's humbling to know that I've impacted that many folks, and obviously want to impact others as well. So please share the podcast as much as you can if you enjoy it, if you benefit from it. I greatly appreciate that. Questions, comments, suggestions, feel free to reach out. mededucation101@gmail.com. You can connect with me on LinkedIn as well. Of course, support the sponsor, meded101.com/store. We've got tons of resources there. Pharmacists, pharmacy students, med students, nursing students, all sorts of resources, books, review courses. Go check those links out and support the sponsor, meded101.com/store. With that, I'm going to sign off. Thank you so much for listening. Take care and have a great rest of your day.